welcome to the NGPG Quality Grand Round Series. This new series will be offered quarterly with topics centered around quality and safety. There is no commercial support for today's program, and any financial relationships of the planners and speakers have been mitigated. If you have a question for our presenter, you can enter your questions into the Q&A section, and we will read them aloud at the end of the presentation during the question and answer segment. I will put a link to the event survey into the chat section toward the end of the program, so you can copy the link from there. And now I'd like to ask Dr. Schnibben to introduce today's speaker.
Absolutely. Thank you, Suzanne. I have the pleasure of introducing one of NGPG's new endocrinologists that will be joining the practice this summer. We are extremely excited to start offering endocrinology services for our NGPG patients. Dr. Ganesh is an accomplished endocrinologist with over 7 years experience in teaching, research, and patient care. She completed her postgraduate training in internal medicine at Cook County Health, Chicago, and fellowship training in endocrinology, diabetes, and metabolism at Rush University Medical Center, Chicago. She then served simultaneously as the attending endocrinologist at the Cook County Health, Chicago, and as an assistant professor at Rush University Medical Center. As core faculty, she had an active role in the training of residents, medical students, and in the mentoring and evaluation of endocrinology fellows. She has given several grand rounds at both institutions and has been part of several quality improvement projects, administrative and protocol development initiatives, and research studies. She is a member of the Endocrine Society, American Diabetes Association, and the American Association of Clinical Endocrinologists. She is a fellow of the Endocrinologist Alliance Academy and is also due to receive the honorable distinction of Fellow of the American Association of Clinical Endocrinology at this year's AACE National Meeting on May 17th. She has a significant interest in diabetes technology and bone and parathyroid disease, and has especially loved the way technology and medicine has changed in recent years for patients with diabetes. Let us welcome Dr. Ganesh, and the floor is yours.
Thank you for that introduction, and thank you for having me here, everyone. It's a pleasure to be here presenting virtually in front of my future colleagues, and I hope this next hour is of use to everyone by the end of this hour. So I have, as I said, no conflicts of interest to declare for today, and the learning objectives for today. NGPG could not have given me a more difficult topic than diabetes and the standards of care and glycemic targets. To be honest, diabetes is one of the hardest things to present on, because if I were going to explain what we call the ADA standards of care, I would be the only one, I think, giving grand rounds for the entire year for NGHS. So I've attempted to focus here on explaining the impact of diabetes, highlighting a few important concepts in what we call the standards of care and why those are important. Go over the pharmacotherapy section of this, and more importantly, the best way to use them to achieve those glycemic targets, and also to highlight a couple of therapies which I think are important for the upcoming year. So just to give you an idea of what we're dealing with, the data that I show here is from this fascinating interactive web application from the CDC website. It's called the U.S. Diabetes Surveillance System. So you can play with it to look at diabetes numbers at a county, state, national level, pick your poison. And if you look at the actual numbers for Georgia, you can see that there's that uptrend in diabetes prevalence over the past 20 years, again, which is good job security for me, which is sad as a population perspective. Georgia is above the national average when it comes to diabetes prevalence. So diabetes prevalence as of 2024 for the country was at around 11.5%. And for Georgia, it's 12.5%. And if you look at who are the diabetics, these are predominantly the 45 plus age group. So the 18 to 45 age group, it's not as bad. You can see the green line at the bottom is actually pretty low. But once we get to the 45 to 65, we're talking about 1 out of every 6. And when we get to that 65 plus age group, we're looking at a 27 to 30% prevalence. That's 1 out of every 3 elderly patients. And we know as physicians that diabetes is all pervasive. And I see it, primary care physicians see it. And as a system who's been managing diabetes without an endocrinologist, I think all of you have seen it, managed it. There's absolutely no running away from it. And ADA periodically releases information every few years about the socioeconomic impact of diabetes. And it's pretty impressive, right? Because 1 out of 10 Americans have diabetes. It's 1 out of 5 if you count adult populations. That's who we're treating. 1 out of 3 patients actually have pre-diabetes. And the best part is the majority of them don't actually know that they even have it. And we saw the age breakup, but if you look at the race breakup of diabetes, the prevalence is lowest amongst white Americans. It's around 9 to 10%. It's about 30% higher if you're a Black American, at around 13%. It's even higher. It's about 55 to 60% higher, somewhere around 16% if you're Hispanic. And that's CDC data. But if CDC includes Asian patients, my blessed race, which is the Indian subcontinent, or people from the Philippines, they have almost 20% prevalence of diabetes, which is twofold compared to white patients. And why do I bring this up is this data is on steroids. It's amplified if the population you're treating is a subtype that has more diabetes than the regular statistics that's presented here. And the indirect and direct cost of diabetes and pre-diabetes in the US is a whopping 400 and something billion. And to put that in perspective, if we look at this is from the federal budget. I just literally took it out from the federal budget website. The blue segment is what the government spends on healthcare. So that's about 35% of the budget. And if you look at diabetes as a portion of that, that's a significantly large slice of pie there. That's 1 out of every 4 healthcare dollars. And to put that in perspective, the federal government actually spends the same amount, if not less, on veterans benefits or on civilian and military retirement. So it's not a mean problem we're dealing with. Now, knowing the impact of diabetes, ADA basically came up with what we call the standards of care. And why is this document important, right? So the first ADA standards of care, which was guidance for practitioners on how to manage diabetes, came out close to 1990. It was a beautiful 4 pages long. My life would have been a lot simpler at that point of time. But in the most recent edition, it comes out in January every year. So January of this year, it's over 350 pages long. So as such, there's no provider who can actually do justice or be an authority on this. It's a group of providers that got together and made these guidelines. And why are these guidelines different from any other guidelines? In any other disease, guidelines come out every few years. But in diabetes, since the last 7 to 8 years, there's new medications being released almost every year. We know this. And it's not just new medications. It's labeling for old medications for CKD, CAD, whatnot. And of course, there's new technology, new pumps. And with that rapid pace of updates in this field, it was decided that since 2018, this standards of care document would be updated every few months. So it's a living, breathing document that's online, which answers almost any question a provider might have for diabetes. And I encourage everyone to use it. I'm going to try to pick on a few parts of it, but it's going to be hard to cover the whole thing. And hopefully what I'm covering is of high yield here. So to move on to the classification of diabetes, I think as a primary care provider and as any other provider who serves as the first point of contact for almost every single patient with diabetes, this is an immense source of power and I think responsibility, because the single most important thing that I think that first contact provider can do is to identify those who might be insulin dependent or type 1 diabetics. Type 1 diabetics make about 5 to 7% of the population. If we're lucky, they present with features of insulinopenia, meaning they're losing weight, they go into DKA. That's an obvious presentation. The more subtle presentations which we learn over time are that they have extremely high glycemic variability, meaning they eat a little bit, their sugar goes to 400. They give themselves a tiny bit of insulin, they drop to 40. So that glycemic variability is seen a lot in type 1 patients. They can have any of those 3 antibodies, but GAD65 is the most commonly detected antibody. Some of them are actually antibody negative. That doesn't rule out type 1. The hallmark of low pancreatic function in these patients is that they have a low stimulated C-peptide, meaning that when the blood sugar is over 70, and this is something that needs to be measured along with the C-peptide, there is no C-peptide being made. The 2025 standards of care now recommend that we screen relatives of type 1 patients for antibodies, and those who have antibodies and impaired glucose regulation or features of prediabetes, you could consider referring them for teplizumab infusions to delay insulin usage. Type 2 diabetics are a garden variety of diabetics. They are basically obese, have other features of metabolic syndrome, and they don't have that up and down glucose variability that's typical of type 1 diabetics. Gestational diabetics, which is that third category, is basically like prediabetes in that it confers a 10-fold higher risk for diabetes later. So screen in the first trimester, screen again at around 24 to 28 weeks with an OGTT. And of course, screen every year after that. And that last category of diabetes is basically our miscellaneous, as I would call it. So these are the monogenic diabetes, which are usually diagnosed under 1 year of age. And they are either syndromic diabetes, which travels with all of those features, or any diabetic who develops diabetes after pancreatic pathology, like pancreatitis or pancreatectomy. Now, where did these glycemic goals that we talk about, where did they come from, right? So prior to the 1980s, the treatment of diabetes was basically 1 or 2 daily insulin injections with occasional blood glucose monitoring. There was no proof that lowering blood sugars did anything for diabetes in the long term, right? It's hard to think of diabetes nowadays that way, but that's how things were. So in the 1980s and 1990s, the DCCT was one of the trials, but there were a bunch of other landmark trials, such as UKPDS, EDIC, which was a continuation of the DCCT. So all of these trials basically defined what we know today as treatment for diabetes. So they were landmark trials that changed the complete course of medicine. I'm picking on DCCT here, but the idea is that UKPDS was similar. DCCT was basically done in about 1,400 type 1 patients who were randomized to what was at that time considered standard of care, which was conventional therapy, which was 1 or 2 shots for type 1s, mind you, with an A1C goal of around 8.5 to 9%. And the intensive arm they were tested 3 or more shots a day of insulin with blood sugar measurements 4 times a day. This is what we know now as standards of care. And the idea was they were targeting intensive therapy with an A1C goal of 7%, with conventional therapy with a more lax goal of about 8.5 to 9%. The corresponding study in the UK for type 2s was called UKPDS. They had a different study design, but the principle was still the same, that they were using insulin and sulfonylureas to try to lower the A1C to 7% versus an A1C of 7.9%. And what did they show, right? The DCCT actually ended up being completed a year earlier than planned. They terminated it early because it was so obvious that lowering that A1C to 7% lowered their chances of developing multiple microvascular complications. You can see clearly here that the difference between those 2 arrows, that the percentage, there's a clear upslope after that 8.5 to 9% A1C range, and the benefit of keeping it lower at that 7% range. And the UKPDS also confirmed the same thing for type 2 diabetics. It wasn't as stark a difference, but it was still there. And both these trials established that an A1C of around 7 to 7.5% was a fair goal for diabetics. Any lower, if you see under 7%, there is still a curve down. So any lower is probably more advantageous. It's not as advantageous as that initial drop in A1C. That point brings us to our next slide. So how low can we go when it comes to the A1C? Or are these goals of 7% even relevant now compared to 20, 30 years ago? Because both the DCCT and UKPDS, they did show that when you further lower that A1C from 7 to 6 or 5.5%, there was a further reduction in the risk of microvascular complication. It's just that the absolute risk reduction wasn't as obvious. However, with that reduction in A1C, there was an almost twofold higher risk of hypoglycemia, which was why they stopped at recommending that A1C goal of that 7 to 7%, because the hypoglycemia risk was just too much. But we have newer medications now. Those studies were done on insulin and sulfonylureas. We have newer medications. Almost all of them are non-hypoglycemia causing medications. We have CGMs. We have pumps. Therefore, the idea is that we could aim for an A1C even lower than 7% if it's possible, without the risk of hypoglycemia, and not just stopping at an A1C of 7 to 7.5%. So how do we actually assess this glycemic status? We keep talking about this A1C, right? So this A1C is, it's something that the ADA recommends twice a year in people who are meeting treatment goals. On the right side, you see those who are not meeting treatment goals, and for them, they recommend at least quarterly or more frequently is what they state. The A1C is a good test. It's widely available. It's standardized. It's basically the outcome that's being used in almost every single trial in diabetics. But in practice, we don't see these patients every 3 months. We end up seeing them every 2-4 weeks, much sooner, and making aggressive changes. Blood sugars and CGM readings can be used at every 2 to 4 weeks. They're not subject to that every 3-month labeling for A1C, and therefore that is one disadvantage that you cannot ignore with using an A1C. Regarding the test itself, the fundamental basis of the A1C is that it measures the percentage of a human's blood cells which are tagged with glucose. So if you have any problems with the actual hemoglobin, or the rate at which the glucose is added to the hemoglobin or the RBCs, or anything that affects the lifespan of the actual blood cell itself, such as kidney disease, vitamin deficiencies, you cannot rely on that A1C. And we read this during our training. It's just that it's a lot more common than we think, in my experience. And I would say that it's to the point where I do not actually trust an A1C unless it's backed by blood sugars. And outside of these interfering factors, there's an extremely important limitation, even if there are no interfering factors. And that is that it has zero information about that glycemic variability or hypoglycemia. And this is where the role of the CGM has come in. For every patient with an A1C of 7%, we can assume that we assume that they're well controlled, which is that rightmost CGM graph. But in reality, we see this where if you look at their sugar readings or their CGMs, it looks like it's the one on the left side. So there's a patient who's spending a significant amount of time low and high, who still ends up coming to the clinic with an A1C of 7%. And unless we actively elicit to get that information, we won't ever know. We would be satisfied with an A1C of 7%. That middle graph is what ADA recommends as somewhat reasonable, a 70% time in range on the CGM, with a little bit of time understandably high and minimal time low. So this is a summary of the most commonly used CGMs. So the Dexcom and the Freestyle Libre, the G7 and the Libre 3 are the ones that we know well. Both of them use calorimetry, and both of them measure glucose in the interstitial fluid, which is that pocket of fluid right under the skin where cells float around. Capillary blood glucose is where we poke the finger, measures the glucose deeper down in the actual blood. So there's a time delay in which the interstitial fluid calibrates with the glucose. So there's an understandable difference between a capillary blood sugar as well as a CGM. And this is something that we usually let patients know ahead of time. Both of them can be worn for about, I would say 10 to 14 days, and they have a reasonable and comparable accuracy as well as warm-up time, and can be worn mostly on the arm. The G7 can be worn on the abdomen as well. And I think by far the most interesting trend in the CGM market outside of these two sensors is that there are now over-the-counter biosensors which are available. Dexcom and Abbott have realized that they can basically take the same software, the same sensor, pair it with a different software instead of diabetic software, and now market it to the healthy population or the non-diabetic population. So these are now available, the Dexcom Stelo and the Abbott Lingo. They don't need a doctor's prescription. You can just order directly for less than $100 a month, and they come with health coaching programs for the pre-diabetic and general health population. So I think there's some role even in our pre-diabetic patients for these kind of sensors. So when you'll see me, as clearly stated in my intro, of course, I have a partiality to using technology in these patients, and that's why I'm batting for the CGM a lot. We know that CGM use independently lowers A1C. And this is data from the Dexcom marketing trial in JAMA in 2017. And if you look at other papers, which are real world data of multiple different kinds of sensors, not just the Dexcom, you will see evidence supporting this as well. If the mere act of placing a Dexcom sensor in these 158 participants resulted in an A1C lowering than control group by about maybe 0.8 to 1% in this trial. If you look at real world evidence, maybe it's not as great an A1C drop, but I would say it's anywhere between the range of 0.3 to 0.8 or 0.9%. And in addition, the duration of hypoglycemia is also significantly less in the control group. So now that A1C reduction of anywhere between 0.5 to 1% is almost as good as some of these medications, meaning if you had to choose between adding a gliptin versus putting on a CGM, you're almost choosing the same A1C reduction. Till now, we had CGM data that showed that it would improve hypo and hyperglycemia, but now, interestingly, we're starting to see that there's mortality benefit to wearing a CGM. So there's a couple of papers that came out, this one specifically from the VA in Arizona, where they looked at patients who started a CGM between 2015 and 2020. These were all type 1 and type 2 diabetics on insulin, and they obviously studied the ones who had a good amount of time in range. And if you look at that, the Kaplan-Meier survival curves for both the type 1s and the type 2 CGM users is definitely better than the non-CGM users. Of course, the benefit is way more in the type 1 than the type 2, but nevertheless, now you're looking at this as a valuable tool for mortality benefit. And if you look at the time of wear in this study, you can see that this is not something that happens over 6 years. This is 500 days on the bottom axis. So you can see that the curve starts splitting by 6 months, and it's already it's even larger by 18 months. So this is quite a short period and an excellent use or advantage of a CGM. So we established that the act of putting on an A1C putting on a CGM reduces the A1C. But now what do we do as the next step, right? Very frequently, we encounter this in practice where the patient has a CGM. It's just that we don't know whether the information it offers is being looked at. And ideally, the way to do that would be the clinic has a cloud account and all the patients are streaming to it via their phone. Not everybody wants to have that CGM app on their phone. So sometimes they use a reader device, in which case it needs to be manually uploaded. And irrespective of what device they're using, this is the data that we need, which is easy to get. If the cloud account is active for the clinic, it's just print out this AGP page. And if it's not, or if there's no cloud account, it requires manual toggling through the settings of either the phone or the reader to get this information. But insurance requires that we look at it, and therefore it's important to know what we need to look at when we place a CGM. So what are we looking at, right? So the first thing is that the patient's wearing the CGM. He needs to be using it at least 80% of the time or as close to 100% as possible over usually a 2-week period is what we look at. The goal time in range, meaning in between 70 to 180, the patient needs to be spending 70% of their time. The GMI, or glucose management indicator, is what the CGM generates as a pseudo A1C, and it correlates with the A1C. And I use this with patients as telling them that, hey, if you maintain what you're doing in 3 months, you can expect your A1C will look like that, even though it didn't look like that last time. And the fourth thing is time below range, under 70. Ideally, you don't want any time below range, but if you have to have it, it needs to be mild and under 4%. Because every 1% time in range is 15 minutes a day. That's a lot of time to be spending hypo every single day. And the last is this glycemic variability or glucose variability that I brought about. You don't want the patient to go up and down, which is independently bad for some of these microvascular complications, especially the eye. The retina doesn't like that up and down of blood sugars. So you want that to be under 36%. So this exact AGP is a fantastic example of how, if you look at just the A1C, the patient would have turned up with an A1C of 7.5%. But if we look at the actual blood sugars or the CGM, you can see that the patient clearly is not doing well with that many hypos as well as hyperglycemia. Moving on to the next section, after obviously canvassing for the use of CGM, this is the sort of the bulk of the presentation, which is the pharmacotherapy and how to use it. But before we talk about the drugs, I think it's very important to focus a little bit on the lifestyle part. To be honest, we don't receive as much training about this I think in residency or even in fellowship. And the fundamental principle behind treating diabetes and pre-diabetes is that it's preventable. This is not said, I think, enough to patients. And the actual scientific basis for lifestyle intervention was established in the DPP trial. And over 3,000 participants, they were randomized to 3 arms, which was either placebo, meaning they didn't receive any drugs or training about lifestyle. The second arm received metformin, and the third arm received intensive coaching over the first 24 weeks about maintaining 150 minutes a week exercise, which is brisk activity. They called it as moderate activity that could be done with a walk 30 minutes, 5 days a week. And in addition to that activity, they needed to lose 7% of their body weight by maintaining a low-fat diet. Again, we know different diets work. They picked a low-fat diet. And what did they find? Right? They basically saw that the lifestyle arm, as you can see, outperformed pretty much of the metformin and the placebo arm by I think, a huge amount. So lifestyle arm, the incidence of diabetes in the lifestyle arm was 58% less compared to placebo, while metformin was only 34% less. And we have 15-year follow-up data showing that lifestyle arm maintained their ability to stave off diabetes. And even if they did develop diabetes, maybe they had even a lesser microvascular complications. So what can we learn from this as providers, right? Lifestyle should actually be offered as the first intervention for anybody with pre-diabetes as a way to stave off diabetes, and of course be as it's a valuable complement to our pharmacotherapy in our diabetics as well. The second thing is that frequent reinforcements work in diabetes and lifestyle management. So we have that uncontrolled patient. Health maintenance sort of takes a back seat. And when we focus on medication changes and hammering in those medication lifestyle changes, that 2 to 4 weekly repeated follow-up really works when it comes to diabetes. We have proof of that here. And the type of diet doesn't really matter as long as it's sustainable. They did it with a low-fat diet. We know keto diets work. We know Mediterranean diets work. We know there's different ways to get to the endpoint in diabetes. But what we cannot deny is that there's that one diet that really doesn't work in diabetes, and that's the Coca-Cola diet. I tell that to my patients that, hey, when they walk in, I'm asking that every single visit and saying, hey, whatever medication I'm giving you right now is not going to fight that regular Coke. It's just not going to work. So we reinforce that at every single visit. It's hard to do, But at the same time, this is where CDEs come in as a complement to our clinic. We know it's busy. We cannot focus on this. We know we're supposed to do it. It's just that it's hard to do. So if we look at the actual 2025 algorithm for from the ADA, it actually, I've split it into 2 slides just because it was that busy. Until about 2021, that top spot was occupied by metformin. But starting in 2022, it started moving down further and further down the algorithm. Sulfonylureas, I challenge you to find it on this algorithm, and yet we use all of these in management. That backtracking of metformin, I don't know if endocrinologists agree with it, and that's a separate issue that I'm going to bring about in the next slide. But this left side of the algorithm basically prioritizes choosing medications based on what kind of complication the patient has. So if the patient has ASCVD or heart failure or CKD, typically we use an agent which has proven benefit in these microvascular combinations. And you cannot go wrong when you choose a GLP-1 or an SGLT2. That's what they recommend. If you're choosing an SGLT2 inhibitor, you can choose it all the way until a GFR of 20. Previously, it wasn't as low, but you can use it until you can start it all the way until a GFR of 20, and you would continue using it even until dialysis. If you look at the right side of the algorithm, it prioritizes weight management. So if you have a patient who has weight issues, which is a large percentage of our population, you would pick that semaglutide tirzepatide duo, any one of those two, because they're high potency weight loss drugs. If we can't get them, use Trulicity or Victoza, which are slightly less weight loss potency agents, but nevertheless they do have some. And the last sort of leftover category, that's where metformin and sulfonylureas now come in. They say that you can use any agent for those patients who don't have complications or don't have weight issues. You can use any agent, just prioritize avoiding excuse me, hypoglycemia. So it's important here to have a slide for diabetes, for metformin. I think as an endocrinologist, I can't let this go. So the origin of metformin, it's actually somewhere in the 1700s. So there's a plant called French lilac, which is known to have glucose lowering activity, and it was traditionally used for this. They tried testing derivatives of this to treat diabetes in the early 1900s and found that they couldn't because there was lactic acidosis, GI side effects, etc. And the poor metformin was clubbed with its sisters, fenformin, buformin, etc. And it took some time to dissociate and build up a good name for itself. And eventually it was used to treat diabetes for the first time in France in 1957. So that's when it started being used, even though we know it's around for a lot longer. In the UK, it was being used earlier than it was in the US. It was approved in the US in 1995. And the UK PDS actually established its cardiovascular benefits. So it started making its way into the algorithm after. Despite having, despite it being around for 200 years, we actually don't know clearly how it works. It seems to work on hepatic gluconeogenesis. It sensitizes muscles to insulin to glucose, to increasing glucose uptake by increasing insulin receptors. And then it delays the absorption of glucose in the intestine. And through this multi-pronged approach, the A1C reduction is easily north of 1%. And for a drug that's cheap, been around, has these many modes of actions, we find in practice that it's actually given up on quite easily by patients. And it's, in my experience, most patients actually pass a re-challenge by typically moving it after food, which again, no other medicine in diabetes is used after food. It's only this one. So you can take it after food. It's easier on the stomach, or by lowering the dose, or by switching to an extended release version. It's just that every little bit counts, I think, in these patients, just because it's that strong a drug. The one caveat is that it may affect B12 absorption. So in a patient who has neuropathic symptoms, we have to test it. Of course, we have to test it in everybody else too, but then especially in those who have a reversible cause of neuropathy, you don't want to let go of that. And the last thing is that all of these newer agents, again, all these newer agents, when they were done, the studies were done, they were done in patients who were already on metformin. So if you want to mimic that population, ideally you want them to be on some little bit of metformin, I would think. Our next class of medications are this generation's heroes, the GLP-1 agents. So in a normal person's gut, ingestion of food actually releases gut hormones. These are called incretins. They're GLP-1 and GIP-1. GLP-1 is a little bit more like it goes everywhere in the body. It goes to the pancreas where it stimulates insulin production, glucose dependent, only related to meals, not sulfonylureas, which is glucose independent production throughout the day. So it increases glucose insulin production from beta cells. The beta cells and the alpha cells actually talk to each other, and therefore there is that paracrine effect from beta cell to alpha cell, and there's suppression of the glucagon production. And combined with these two actions, so basically there's this profound decrease in blood glucose, which really leads to that 1.5, 1.7% reduction in A1C that we see. The GLP-1 receptors are also in the hypothalamus and brainstem, so they suppress appetite that way. They're present in the vagal afferent neurons, and because of this, they slow down gastric emptying and cause nausea. This particular effect has been shown to have tachyphylaxis, meaning the receptors are down-regulated. So patients who have nausea those first 4 weeks, it might improve over time. It's present also on the pancreatic exocrine cells, and constant stimulation of this may lead to that pancreatitis labeling or caution with pancreatitis that we see in these particular agents. Again, this is patients with pancreatitis who don't have an etiology that was found when they had it. Excuse me. And lastly, they are present on the GLP-1 receptors are present on thyroid C cells. So that's not the actual thyroid follicles. It's in between the follicles and makes calcitonin. And stimulation of these has been shown to cause medullary thyroid cancer in rodent models, not in humans. Again, most thyroid cancers are not medullary. They're pretty rare. So most of them are papillary thyroid cancer. So you can use these in papillary thyroid cancer patients. It's just that there's a black box warning for medullary thyroid cancer. So what about the newest member, right? It's called tirzepatide. So we sort of call this a twin incretin. So unlike GLP-1, the second the incretin was a GIP, it's not as all-pervasive in the body. The primary action is in the pancreas, where it increases insulin secretion from the beta cell, and in adipocytes, where there's increased metabolism and the lipolysis. Now, in diabetics, there is a state of GIP resistance. So GIP is floating along, but then there's a high level of GIP that's not really doing these two things in diabetics. And there have been numerous attempts to try to make a diabetes medication that targets the GIP receptor, which really didn't work until they found tirzepatide. Tirzepatide is a novel agent in that it has a lot of affinity to GIP receptors, but a little bit of affinity to GLP-1 receptors as well. So this specific combination where there's this gentle priming of GLP-1 receptors and a lot of GIP action, for some reason makes that pancreatic beta cell really responsive to both receptors being activated, and there's this flood of insulin production, glucose-dependent insulin production, which leads to that 2% reduction in A1C. Now, these are a list of the available incretin agents. They deserve, of course, a separate grand rounds by themselves, so I cannot promise to do justice to them. The bottom 5 rows, starting from dulaglutide onwards, so those are the ones we use in practice. And I think dulaglutide and liraglutide, even though they're not used as much, they still have importance in those non-obese patients, as well as those that cannot get the other two approved. I do think that it's important to talk about them. The weight loss versions of Victoza, Ozempic, and Mounjaro are basically Saxenda, Ozempic, as well as the Zepbound. So, sorry, my mistake. Saxenda, Wegovy, and Zepbound are basically the corresponding weight loss versions of Victoza, Ozempic, and Mounjaro. So they're basically high-dose versions of the same drug. And in addition to being approved for diabetes, now you're seeing these new labelings come out for all of these medications. So there you go. So dulaglutide, liraglutide, and semaglutide are actually approved for cardiovascular risk reduction in diabetics. Wegovy, which is the non-diabetic version in obese patients, is actually approved for cardiovascular risk reduction in obese patients in non-diabetics. In the nephrologist's world, Ozempic was recently approved in January 2025 for CKD disease progression in diabetics. And around the same time, you had Zepbound being studied for OSA and being approved for this indication for moderate OSA. So now you can see all these other indications cropping up. And you can expect to see more too, because data is being submitted and reviewed by the FDA for these additional indications, which are MASH and heart failure with preserved EF. So as you can see, absolutely there's no specialist that's escaping the use of GLP-1s. So moving on to the next class of medication, which is the SGLT2 inhibitors. So these are basically drugs which block the reabsorption of glucose in the proximal tubule. The available SGLT2 inhibitors all act in the gut. There's one SGLT2 inhibitor that acts as on both SGLT2 and SGLT1 receptors, SGLT2 in the kidney and SGLT1 in the gut. And that's actually not approved for diabetes. It's called Inpefa. That's the brand name. Sotagliflozin is the actual drug name. It's approved for heart failure in the US. The important thing to notice with SGLT2 inhibitors is that it depends on the amount of drugs being delivered to the kidney. So if, again, there's not enough being delivered to the kidney in terms of reduced GFR, then you're not going to have as much an anti-glycemic effect at the lower range. So these are the FDA indications for the approved SGLT2 ones. All of them are approved for diabetes. DAPA, EMPA, and canagliflozin are approved for cardiovascular risk reduction in diabetes. All of them are approved for heart failure management, both preserved and reduced EF in diabetics. And in addition, DAPA and EMPA are again approved for heart failure risk, readmission risk reduction in non-diabetics. For CKD progression, all of them are actually approved all of them are approved for halting CKD progression in diabetics, with DAPA and EMPA being approved even in non-diabetics. Now, in type 1 diabetes, there's evidence that there is some glycemic control, weight reduction, and blood pressure reduction benefit for these agents. It's just that there's that increased risk of DKA, anywhere between 2-3-fold all the way until 10, 12-fold in studies. So that's something that we cannot really ignore. And ADA cautions that you would really need to pick that particular type 1 who's extremely active about ketosis reduction to use it. I really don't use it just because of that. I've not met that kind of patient just yet. I'm going to bring up this case next to illustrate my next point about choosing the right agent for the patient. So this is a 48-year-old woman, an A1C of about 11%. She's morbidly obese. She reported having side effects with metformin, and she was on glipizide and Jardiance. And the plan at the time of the referral was to add linagliptin, right? So can somebody tell me what's happening here and why this won't work, right? And for the interest of time, I'm going to say, move on to the next slide. I wish I were there in person to actually see if everybody could pick this up. The idea is we see this extremely commonly in practice, where we are dropping a drop of water in the ocean. That's what we call linagliptin, such agents, when we're treating an A1C of 12%. So this is an extremely common cause of uncontrolled sugars that we see. For a BMI of 42, this patient is extremely insulin resistant, which is why she has that high A1C. And we really want agents that drive it down, right? Drive that A1C and weight down. So this is arranged in a descending order of A1C reduction. And you can see that there's, I've also color-coded them for that weight loss benefit. So this patient is on sulfonylureas, which is a good A1C reducer, but makes the patient gain weight. SGLT2 inhibitors, again, they're okay for weight loss and okay for glucose reduction, but not really the big guns. And DPP4, I would say, is almost placebo in this patient because it's just not good for weight loss or glucose reduction. What we need are those big, strong guns. So we're talking about that tirzepatide, GLP-1, either of those agents. And let's not forget metformin, our good friend, which is also of help in these patients. And if we're going to add insulin on top in these patients, it's very important to do this on a background of insulin sensitizing therapy so she doesn't gain more weight from insulin. So back to our patient, she actually did really well on Mounjaro, metformin. She passed a retrial, and basal insulin. So she actually did well after she lost weight. So in my head, if I have to think about a simplified algorithm for diabetes, it's basically metformin and lifestyle for everybody. Again, even in type 1s, I use metformin off-label just to increase that insulin sensitivity. For weight issues, we would use a an incretin agent. For CHF1, the best is SGLT2 inhibitors. For anybody with CKD or CAD, we would add one of these two agents with proven benefit and add the second agent if we need it. As you can see, you cannot go wrong if you pick a GLP-1 and an SGLT2 inhibitor combination in most cases. These medications, almost all of them, with the exception of metformin, are all prandial medications. They don't affect hepatic gluconeogenesis, which is what is the source of glucose when patients are are sleeping. So for that, you would have basal insulin. So if you look at whom to add insulin over time, you can see that the beta cell function, irrespective of patients are obese or non-obese, or whatever diet they're taking, most patients enter diagnosis of diabetes with 50% function. And this is from UKPDS. Initially, there's a little burst in they recover some function, but over time, everybody with diabetes has that decline in beta cell function, irrespective of what they do. So it's important for us to understand that patients should not feel punished for having to add insulin because that's just the nature of disease. It burns out over time. And when we add basal insulin, how do we add it, right? So the liver normally makes the gluconeogenesis is the source of glucose in the background, and the pancreas makes a regular insulin at a steady rate throughout the day, which combats that. So the ideal dose of basal insulin basically would keep your sugar levels flat without letting it go up or down because it exactly matches gluconeogenesis output. And then our pancreas makes bursts of insulin whenever we have a meal or are excited or stressed. And correctional insulin, or bolus insulin, is supposed to target those. GLP-1s and other agents also do this. So you may get away with using basal insulin for the background and using these prandial agents for the foreground. ADA mentions that you have to start about 10 units a day, or for a heavier patient who might end up needing more. And if every 3 or 4 days when we check, if the sugar is fasting sugar is over 130, then we would increase it by a couple of units until we reach that fasting sugar, and we do this without hypoglycemia, right? There's a caveat to this, and they caution against this term called over-basalization. And in order to illustrate that, I think I'm going to show you a case. So there's this 52-year-old woman with an A1C of 9%, BMI is pretty high, and she's on a huge dose of glargine at bedtime, which is 90 units. And she was also on glipizide and metformin. Her husband basically said she's had such badly controlled sugar, she keeps eating candy and food, right? Immediately off the bat, that BMI to that glargine ratio doesn't make sense because she's obese, but not that obese to require such a large dose of glargine. What's happening in this patient is we're basically flooding this patient with glargine to the point where it's way more than what's needed by the liver to counteract that hepatic glucose output. As a result of which she's eating to swim out of that pool of insulin that she's on. And that's what happens when we look at only the fasting plasma glucose in order to adjust basal insulin. If we look at your CGM readings, it's a trademark downslide whenever the patient's sleeping or not eating. And we know immediately when we see that, hey, this patient is getting too much basal. And this is something that ADA cautions against. Over basalization is what they use. And there's for a blood sugar of about 160, which is above goal, there's 3 ways to reach it. The patient's liver can put out glucose all night, and therefore her blood sugar raises while she's sleeping. Basal insulin will fix that and bring it down and make it at goal. And this is a beautiful way to use basal insulin. But for someone who reaches that fasting glucose in 2 other ways, either the patient has a hypo overnight and eats to reach that goal, or she's sliding down overnight because she ate, a slice of chocolate cake at night, basal insulin is not really going to fix both those issues. It might actually make the former one worse because the patient's having a hypo. And the third one, where she drifts down overnight, it will get her to a good fasting glucose level, but it will do that at the expense of dropping her overnight if she doesn't eat that chocolate cake at night or she doesn't sleep at a blood sugar of 200. So what do we do in those cases? It's important to use prandial agents in those cases, which are GLP-1s, sulfonylureas, DPP-4s. So these actually will bring down her bedtime sugar and fix automatically the fasting sugar. So it's important to use the right agent based on where we're seeing the problem. So our patient did really well on a lower dose of glargine, metformin, and semaglutide, and a much lower dose of glargine. So she was cautioned to not eat food. And our last section, in the interest of time, I'm probably going to go to the next slide quite quickly. The icodec is something that you're seeing a lot more nowadays. It's a weekly insulin that's given as one giant dose up front. So if a patient who's on 10 units a day is on 70 units a week of insulin, it sounds scary, but that's how it's done. And you can see in direct comparison with glargine, the A1C reduction is actually better with icodec, and this was confirmed on the time in range as well. And there was a slightly higher significance of hypos in that arm, which is why FDA in July last year basically said, we're not going to approve it yet because we're a little bit concerned about those hypos if you can fix it. It's actually approved everywhere else outside of the US. It's just that Novo's taking its time to come back about the icodec answers for icodec. So maybe if they answer that, we might end up seeing it. Retatrutide is another peptide which is new. We're hearing about it more. It's a triple agonist. In addition to GIP, which is really high affinity, it also has GLP-1 and glucagon receptor agonists. And you can see here that in the dark blue line, you can see mid-study period, the weight loss was about 17%. And at 48 weeks, it was about 24% compared to placebo. And why are we excited about this? We're now talking about weight loss in ranges that we have achieved before only with gastric bypass surgery. So it's it's groundbreaking that medicine is able to compete with that. Phase 3 trials are being done. And of course, if everything comes through, maybe we'll see something next year. And lastly, orforglipron, which is I think it's a step ahead in retatrutide. It's a once-a-day GLP-1, which is oral. It can be taken any time of the day. Phase 2 studies showed good results in 2023. And this data that I'm showing you is actually from the Phase 3. It's hot off the press. Lilly actually came out with this release about 3 weeks ago. So it lowered the A1C at 40 weeks by 1.5%, and the weight loss was about 8%. And they were continuing to lose weight still while they reported these results. So more results are expected from the Phase 3 trials. And again, we might end up hearing about it by the end of this year. So in summary, a few things that really, really help, I think, with uncontrolled patients. Hypos and diet and lifestyle are almost part of a diabetes intake. I think, did you change the way you eat? Did you have any hypos? So this is something that I think every visit really gets a barrier out of the way when we're managing diabetes. Just as we saw in the DPP-4, CGM initiation itself, of course, leads to an A1C, but those frequent follow-ups that we saw in the DPP really work when it comes to uncontrolled diabetics. Metformin shouldn't be given up on, I think, whenever possible, just using it as much as possible, and using drugs according to where the hyperglycemia happens, as well as the magnitude of use the big guns when it's needed. I think these are the two major things that will really help with uncontrolled patients. Thank you, and I am open for questions.
Okay, it says, looking forward to working with you from the diabetes team. This is from Rachel Oswald. Hannah Day says, great presentation. Thank you. That is it. Thank you, everybody.
Thank you so much.
All right, have a great day.